that's why myths and misconceptions have become such an important part to be cleared by all doctors, because with so much of information that keeps rotating. Second myth that I very commonly hear, especially when a patient comes to me, is that the minute they're going to go ahead and do a biopsy, it is going to result in spread of cancer. Cancer is contagious. If that was true, we would definitely have cancer, because we see cancer patients day in and day out. The further the stage of diagnosis, like if it is stage 1, the further the chances of cure and the lesser the chances of the disease coming back. But if you're diagnosed at stage 3, stage 4, there's no cure.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like video so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
So, hi everyone. I'm Dr. Bushra. I'm a breast surgeon. I deal with both benign diseases as well as breast cancer. So this topic is something which is very commonly heard by us in the cancer specialty in oncology, and that's why myths and misconceptions have become such an important part to be cleared by all doctors, because with so much of information that keeps rotating and coming up on social media, and with many non-medicos claiming to be extremely knowledgeable regarding the topic, there is a lot of buzz regarding cancer, which makes the disease much more difficult to treat. And that's why it is upon us as doctors and physicians to actually get to the public and patients what's right and what's not. So let's begin. So, starting with why busting myths is so critical for all of us. Firstly, because as a general practitioner or as a family physician, especially as a family physician, no matter whether you're in the surgical field or whether you're a general physician or whether you're a super specialist, patients trust your words. Misconceptions commonly delay diagnosis and even treatments. There are so many patients who come to me in such later stages of the disease, and it is just because some random person who claims to have knowledge about cancer has told them, no, don't go to an oncologist or a cancer specialist and do so, and everything will get better. Misinformation is rampant, even among healthcare workers. Yes, so what happens is sometimes some of us do get influenced by what is told by influencers, and we also have misconceptions that need to be cleared before we jump onto any conclusions. Let's start with the basic myth. Like in today's topic, I'm not going to be talking about very hi-fi medical facts. I'm going to be covering the literal basics and the myths that are there and are associated with cancer, because these myths have become such an important part of our, especially my day-to-day work culture, and this impacts treatment of cancer a lot. And with cancer on the rise, it is important that all of us are aware and that we're able to counsel and support patients as well. With this, cancer is always a death sentence. So this is actually no longer true. Cancers, most of the cancers, 90% of cancers, if they are on an early stage, their 5-year survival is almost more than 85 to 90%, which means that breast cancer, an early pickup of breast cancer in the early stages, the chances of cure are around 90 to 95%, which means that the risk of the disease coming back is less than 5%. So definitely, whenever anyone hears the word cancer, especially a lot of our patients at the time of diagnosis, you can see the kind of panic that rises on the patient's face as well as in the face of the attenders, because they feel like the next question that comes is, how long do they have to live? So thankfully, with everything that is going on in the research and development field, cancer is not always a death sentence. If picked up early, if diagnosed early, it is treatable, it is curable, and fortunately, it is in controllable today, even if it's in the late stages. The second myth that I very commonly hear, especially when a patient comes to me, is that the minute they're going to go ahead and do a biopsy, it is going to result in spread of cancer. So let's take an example of oral cancers. So among men in India, oral cancers is the most common cancer today because there's a lot of consumption of tobacco in all its forms that takes place in India, especially in the most raw form, that is gutka and tobacco chewing. So what happens is they feel that the minute I go into their mouth and take a biopsy, whether it is from the cheek or it's from the tongue or anywhere, they feel that it's going to result in spread. So this is not true. Okay. What happens is, and why this misconception probably started, is that the patient goes ahead after the biopsy, comes to know they've got cancer, goes on to alternative forms of treatment, takes their own sweet time, and definitely cancer does not stop spreading. It is not the biopsy which causes the cancer to spread. It is the delay of treatment which causes the cancer to spread. So there's no scientific evidence to support that a biopsy causes cancer to spread. Tumor manipulation does not cause metastasis. It does not cause distant spread. Delay of treatment is what causes spread. The next myth is superfoods and alternative therapies cure cancer. So, no. The extensive amount of research that allopathy, which means chemotherapy, surgery, radiation therapy, hormonal therapy, immunotherapy, target therapy, puts into the treatment of cancer, no other field of alternative medicine has done such extensive research and controlled trials as far as cancer is concerned. So going ahead with alternative medicine treatments just delays treatment and causes the disease to advance from stage 1, and I've seen it advance to stage 4 as well. So no alternative therapy has cured cancer in controlled trials, and they only delay treatment. So if a patient ever asks you, can I go with an alternative treatment other than chemotherapy or immunotherapy or surgery and proceed with it, then please tell them no. Finish your entire treatment that is there as per research protocols, and then once you're treated and you're in the phase of remission where you do not have the disease, feel free to try these alternative therapies, but at the same time continue to visit your oncologist and follow up closely. Myth 4. Cancer is contagious. If that was true, we would definitely have cancer because we see cancer patients day in and day out. So no, cancer is not contagious. It is not infectious. Yes, some viruses increase the risk of cancer, such as the human papilloma virus, the hepatitis B virus, the Epstein-Barr virus. But again, cancer is not contagious. It does not spread by contact or by touch. Myth 5. Only smokers get lung cancer. So unfortunately, this is not true as of today. I would say more than 20% of lung cancer patients have never smoked. I personally had a 36-year-old male patient who was diagnosed with lung cancer with metastasis at the age of 36, and he had never consumed tobacco or alcohol ever in his life. Radon, air pollution, genetic factors also matter. Air pollution has become a rising cause of exposure to lung cancer. And that's why the best way we can actually do, we cannot change the quality of air, but we can definitely avoid smoking so that our chances of lung cancer getting accelerated and the risk factor does not increase. Myth 6. Cancer is one disease. No. So a lot of patients come to us and they come to me and tell me, so and so relative of mine got treated with this and this treatment, but you're not doing the same for me. Or they go like, so and so a relative of mine did not have hair fall when they took chemotherapy, so I want the same kind of drug. But that's not how cancer works. There are like so many cancers, and every cancer has its own protocol and own way to be treated. In fact, with just taking one simple disease like breast cancer itself, not every patient and every case of breast cancer is the same. We don't start with chemotherapy for everyone. We don't start with surgery for everyone. We don't give radiation upfront to anyone. We don't do a toilet mastectomy or a reconstruction for everyone. So every patient and every case of even breast cancer being different, every case of cancer is absolutely different, and they definitely need their own customized way of treatment. That is why tumor board meetings come and play such a major role in cancer treatment because you have the entire team that is of medical oncologists, surgical oncologists, radiation oncologists, you have radiologists, you have the pathologist, you have different team members, multidisciplinary, who come together to actually talk about and decide the treatment and line of protocol which is ideal for patients with different types of cancers, especially complicated, uncommon cases. Myth 7. Cancer always means chemo. So no, cancer does not always mean chemo. Chemotherapy comes into play depending upon your stage of the disease. Chemotherapy comes into play depending upon the type of cancer you have. Many cancers don't need chemotherapy. Surprisingly, most oral cancers do not need chemotherapy because chemotherapy does not work wonders in them. Surgery, radiation, immunotherapy, hormonal therapy are not alternatives. They, depending upon what kind of cancer treatment is there, we have to channel the treatment accordingly. We have to plan the protocol accordingly. Myth 8. There's a cure that pharma is hiding. This is something which I hear so very often. So the thing is, if there were drugs that treated cancer, I think pharma companies would be the first to bring them out because they'd make money out of treating cancer rather than hiding the treatment. So definitely, there are no incentives to hide cures, and cures are extremely profitable. Immunotherapy, target therapy being on the rise, there's a lot of buzz which is there in the medical oncology and the pharma market to actually bring up drugs which compete and even generate those drugs in India, the generic versions, so that they're available at a lesser cost and to greater population. How can you help bust myths? So this was just a very brief overview of something that I commonly hear, but there are a lot more myths which are related to specific products. For example, I had heard, like in many of my sessions, a lot of women thought that using sanitary napkins increases your risk of cancer. That is not true. Okay, many of them thought that even using certain types of menstrual cups increases your risk of cancer. That is not true. So yes, at the end of this session, we can talk about what you think or what you've heard causes cancer, and we can bust them accordingly. So how can you, as a doctor, help? Be informed, share evidence. Whenever you're talking, make sure you've done your own research and you share your own link of research that is there as per the research guidelines or the trials that have taken place. Don't act arrogant. Don't try to tell them that, okay, just because I'm a doctor, I know this is right and wrong. Use empathy. Tell them this is out of personal experience, or I use this with my family as well. Like, for example, there is no proof that using aluminium causes cancer, but it does cause a lot of metabolic derangements. So I personally put a personal touch into it and tell them that, look, I don't keep hot food wrapped in aluminium foil because I feel it's unhealthy for my child's health or my parents' health. So something like empathy, which can be used to make them understand so that they know that it's more relatable and this is not coming out of a place of pride or arrogance. And definitely guide patients towards trusted sources if they like to read. You have NCCN, you have the ESMO guidelines. They can definitely be directed towards these guidelines. Okay, what's real and what's not? A quick recap, review misconceptions, realities, and why it matters. And next is the cancer survival rates. Okay, so definitely if we look at it, we have different kinds of survival rates that come according to different cancers. Okay, whenever you talk about survival rates in cancers, everything, depending on the recent research, has definitely picked up. And as early as cancer is diagnosed, the cancer treatment protocols, because they have changed, the chances of survival have increased. Okay, so definitely earlier stages of diagnosis, the survival in breast cancer is almost 90 to 95%, I would say. Colon and rectal cancers. Now, when I use this term 90 to 95%, we're looking at a 5-year survival rate. We're not talking about lifetime, but also the chances of the disease coming back is less, and they do very well in the long term. I've seen patients who've been disease-free for almost 20 years of their life, and they're still on regular follow-up. Prostate cancer is one of the cancers which unfortunately does get diagnosed a little late, but the 5-year survival rates for prostate cancers are quite high, even if they're metastatic prostate cancers. Colon and rectal cancers, again, quite an aggressive cancer if diagnosed late, but if diagnosed in the early stages, like stage 1 and stage 2, the chances of complete cure would be a 5-year survival rate of approximately 70%. Lung cancers are divided into multiple categories, and depending upon the type or subtype of lung cancer, it differs accordingly. And if it is a metastatic lung cancer, then the chances of survival are not there. It would only be control of the disease. But if it is a good variant of cancer, the chances of survival would be around 40 to 50% at 5 years. So definitely, if you look at it, a basic mechanism of metastasis which is there, you've got the primary tumor site, and this is a lot in detail, but definitely the site of metastasis, what happens is that the first source, there's a hematogenous spread, there's a lymphatic spread, and there's direct implantation also. So the first source of spread would be the lymphatic spread that is there, and that has become the basis of the newer technology of using sentinel lymph node biopsy, which can be used in conditions such as breast cancer, endometrial cancer, even penile cancer today, and melanomas. So in breast cancer, what we do is, depending upon where the tumor is, we infiltrate indocyanine green or methylene blue dye, which is going to be infiltrated into the nipple areolar complex area, and with the help of a probe, we identify the sentinel lymph node, which is also called as the guarding node. That is the lymphatic route of spread. Hematogenous routes of spread are there, and direct implantation is also there. The most common type of cancer among women in India and women all over the world is breast cancer. And as of today, the most common type of cancer in men is oral cancer in India. Various cancer treatment options are available today. You've got hormone therapy. We'll start with surgery, chemotherapy, and radiation therapy, 3 of the most commonly heard and known. But now you've got even hormonal therapy. You've got bone marrow transplantation, which is also a treatment protocol which is there. Targeted therapy, immunotherapy. Now, one thing which I really want to speak to everyone today about is screening for cancer. So myths and busts, like busting those myths is important. But then a lot of physicians need to know how to screen a patient for cancer. Why? Because nowadays, with the awareness increasing among patients, they do come up to us and ask us, say, I am so age. At this age, what do I get done so that I can pick up my cancer at the earliest as possible? Definitely, to prevent cancer, we tell them to exercise, we tell them to avoid tobacco and alcohol consumption, we tell them to keep their weight under check, to eat healthy, to have a balanced diet, promote mental and physical well-being in all its forms, and be aware of your family history. But in terms of screening for cancer, why do we do and what do we do? Why do we screen? Very importantly, we screen because there are certain cancers which are amenable to early detection. Breast, cervical cancer, oral cancer, and there are very simple tools to actually diagnose them at the earliest. Standard protocols are in place for management of screen-detected precancerous and cancerous lesions, and high cure rates if detected in the early stage. So if we just have to look at risk factors of breast cancer, we talk about the female gender being a risk factor, because definitely breast cancer does happen in males as well, but it is very less as compared to breast cancer in females. With increasing age, the risk of breast cancer increases, but today I saw a patient, like just yesterday, 32-year-old. She got diagnosed with breast cancer. So definitely young breast cancers are on the rise, but one of the risk factors is increasing age. Alcohol consumption increase the risk of cancer. Radiation exposure. For example, if a patient has a history of being a Hodgkin's lymphoma patient and has received radiation for Hodgkin's at an earlier age, in the future, in the next 20 to 30 years, she might be at risk for breast cancer as well. Genetics, very important, okay? Because if there is a family history of breast cancer, be it your maternal or your paternal side, be it your aunt, your first cousin, your grandparents, your grandmothers, definitely there would be a genetic risk factor that is present. And in such families, how do you deal with it? Suppose if the person who has actually been diagnosed with cancer is alive and doing well, get them first tested for the gene, and if it is positive in them, then it makes sense to go ahead and test the family and counsel them accordingly. Definitely hormone replacement therapies, which are taken and prescribed commonly by gynecologists. It is very important that while the patient is on hormone replacement therapy, they closely monitor their breast health, because breasts are hormone sensitive organs and the risk of breast cancer can increase with HRTs. Obesity is a very important risk factor and something that we need to make our patients understand that that is something that can be easily taken care of. What are the breast cancer screening options? Starting with the most basic one, which you can do at home itself once a month, something which is called as breast self-examination. Make sure you tell your patients about this, make sure they're aware about it. What is the technique? Once a month, preferably 5 days after your menstrual cycle, stand in front of the mirror, inspect your breasts, make sure that there's no visible lump, there are no skin changes, the nipple areola complex is same, there's no rising above or drooping below of any of the breasts or the nipple areola complex. Then the second step of self-breast examination is what is called as palpation. With the flat part of these 3 fingers, make sure in circular motions the entire breast and underarm is examined, again to check for any lump, any pain that is not subsiding, any wound that is not healing, any skin changes that are not subsiding again. Clinical breast examination. Once you notice something, make sure you show yourself to a specialist who then does his or her clinical examination to evaluate you. Above the age of 40, we'd prefer a mammography. Below the age of 40, an ultrasound. Suppose if there is a strong family history of breast cancer, we can start screening at a younger age, even with an MRI. Next, we move on to cervical cancer. Cervical cancer and its risk factors would be as follows. 80% of all cervical cancers are caused by the human papilloma virus. Other than that, you've got smoking, multiparity, that is having many children. Immunosuppression is also a risk factor for cervical cancer. Multiple sexual partners and sexual intercourse at a young age is also risk factors for cervical cancer. The cervical cancer screening guidelines. How do we screen for cervical cancer? We do something which is called as a pap smear. So preferably between the age of 21 to 30, okay, pap smear done once in every 3 years. If it is between the age of 30 to 65, pap smear can be done every 3 years. Or if you're doing an HPV DNA testing, you would do it once every 5 years. Post the age of 65, in case you do not have any complaints, it is not required to do regular testing. Women who have had a hysterectomy and no prior history of any risk factors or precancerous changes, you can tell them to skip the screening, but if they do want to get a pap smear done, there is no harm in it. Risk factors that cause oral cancer. Tobacco consumption in all its forms, supplemented and aggravated by alcohol consumption in all its forms. Smoking is also a risk factor for oral cancer, and also infection with the HPV virus. As a doctor, as a physician, when you're doing oral cancer screening, it is very important that you inspect and you examine, if required, palpate all parts of the oral cavity. You will check the gingiva, you will check the buccal mucosa, you will check the upper and the lower alveolus, you will check the tongue, you will check the palate, you will check the posterior third of the tongue, the base of the tongue, the floor of the mouth, and the lateral borders as well. So the entire oral cavity, including the uvula and the posterior pharyngeal wall, also has to be examined properly. So very importantly, in the lung cancer screening, what is done is that if they have a long history, which is going to be of of smoking and consumption of tobacco, it is best that post the age of 50, you can actually guide them to do a baseline CT chest. And depending upon that, you can carry it forward. If the patient has any symptoms in terms of cough that is not subsiding, or recurrent upper respiratory and lower respiratory tract infections, you can go ahead for a baseline CT before that. Colorectal cancer screening. Firstly, when should you screen? Okay. And why should you get screened? So colon cancer symptoms could include if there's any sort of blood in stools, long-term constipation, very importantly, and stomach pain, which is non-specific and it is unrelatable. Weight loss that is progressively increasing with a decrease in appetite. Long-term constipation or diarrhea, which is difference in bowel movements, could also be a potential risk factor and they can get evaluated. Between 45 to 75 years of age, unless and until indicated, that is, if you are at an increased risk when especially strong family histories associated with certain syndromes such as FAP, familial adenomatous polyposis, the Lynch syndrome, which is HNPCC, these syndromes are associated with a very significant increased risk of colon cancer. And if you have any of those, that is, any first degree relatives diagnosed at a younger age, or any first degree relative or your family proven to be carriers of this syndrome, then definitely it is important that you get screened at an earlier age. Okay? So speak to your doctor about screening. You need to make the patient understand that they need to go ahead with screening, and if they have symptoms at an age of 45, colonoscopy. If the colonoscopy is normal, then you can plan screening accordingly. That is another colonoscopy 5 years later. Prostate cancer and why get screened. Prostate cancer is on the rise, and the main thing with prostate cancer is that men get diagnosed at a later age when metastasis has already taken place. Okay, so as simple, definitely depending upon their symptoms, if they have symptoms of urgency, frequency, incontinence, they need to get checked at an early age, and a simple blood test in the form of serum prostate specific antigen can be done and they can get screened for it. So that would bring me to the end of my session, and these are really basic questions, but I'd really appreciate if you all could answer it. Which of the following is not a known cause of cancer? Hello. Okay, so that's absolutely right. So surgery is not a known cause of cancer. Smoking, definitely. Tobacco in all its forms. Human papillomavirus is a known causative agent of cervical cancer, oral cancer, penile warts, so definitely increases risk. But surgery in none of its forms is known to be a cause of cancer. Radiation exposure, like I told you, the case of lymphoma, where they're treated, even could be a cause of cancer. The next question. Which therapy is not commonly used to treat cancer?
Thank you so much for the presentation, ma'am. I think the audience have quite a few questions in the comment box. If we can then.
Yeah, sure.
Dr. Ram has asked which cancer has the best prognosis and which one has the worst prognosis.
So, talking about the best prognosis, what I would say is that thyroid cancers, papillary carcinoma of thyroid. Okay, particularly, I wouldn't generalize it as thyroid cancers because medullary thyroid cancer is quite an aggressive cancer, but papillary thyroid cancer has the best prognosis. And which has the worst prognosis? Hepatobiliary cancers do very poorly. Gallbladder, pancreas, cholangiocarcinomas do extremely poorly.
Okay. Uh, Dr. Suman Kumar has asked what are the main causes for relapse and recurrence of cancer even after treatment?
Okay, firstly, it depends upon the stage of diagnosis.
Okay.
The further the stage of diagnosis, like if it is stage 1, the further the chances of cure and the lesser the chances of the disease coming back. But if you're diagnosed at stage 3, stage 4, there's no cure. Stage 3, definitely the chances of relapse and recurrence are more. Next thing, it depends upon the aggressiveness of the tumor, something which is called as grade, histopathological grade. In histopathology, there are many subtypes of cancer which are there, some being extremely aggressive and some not being so aggressive. So it depends upon the histopathology and the stage of diagnosis.
Okay. Dr. Ravindra Kulkarni asks which is the ideal test to diagnose ovarian cancer at an early stage?
So the thing about ovarian cancer is most of our patients present at a later stage because they don't really develop any symptoms. So some common symptoms of ovarian cancer would be abdominal fullness. It would be a decrease in appetite.
Hello.
Yeah.
Yeah.
It would be some amount of decrease in appetite which is there. And so, how would you do it? You would first clinically examine the patient. And as such, there is no screening tool for ovarian cancer, but you can go ahead and start with an ultrasound abdomen plus pelvis. And then, in case there is any suspicion of any mass in any of the ovaries, then go ahead and do an MRI abdomen plus pelvis and then proceed.
Okay. Understood. Requesting all the audience members to please put in your questions in the comment box. Dr. Bushra will be taking up questions. Next question we have by Dr. Rajendra Kumar Maheshwari. He asks, what more efforts needed to avoid fear of cancer by common public? Are efforts now done are sufficient?
No, they're not sufficient because, see, cancer as a terminology only is extremely scary.
Correct.
Um, Dealing with it day in and day out, I think I've become very casual with the word. But as such, any person who hears it, be it a medico or a non-medico, is definitely not comfortable with the word yet. And I think we're a long way from actually getting there. So the only thing that can help is counseling. Someone who's been diagnosed with it, you need to reassure them. You need to tell them that, okay, it's not a death sentence. Constant counseling, constant support, it's very important. And
Correct.
that's why even something which India definitely needs to develop is that we have the support groups that are much more there in the West. Like what happens in India is when a patient gets diagnosed, they feel very lonely because the kind of support and openness like patients have here by themselves, even if we do try to organize support groups and support efforts, patients don't really come out and talk. So it is what is important is to have those support groups and have that kind of connectivity, the doctor patient relationship, which puts them at more at ease and less amount of fear. Can this which like can this screen be cleared? The second
Uh,
question is still rotating.
yeah,
It's a little disturbing.
yes. Just give me a minute, okay?
Yeah. Okay, I think we'll continue. It's fine.
Yeah, just our team is working on it. Okay. Um, Can we just rejoin, ma'am? Quickly rejoin and see if it's...
I think it's okay. We'll just continue. It's fine.
Okay. Okay. Dr. Chandrasekhar is asking, please advise on screening tests for cancer.
So, like I just said, if we have to go with the basics, for breast cancer, it would be a mammography once a year as per Indian standards, annually, a mammography for women. And as per the US protocol, it would be once in 2 years. And something like a self breast examination, which can be done at home every month, 5 days after your menstrual cycle ends. And for postmenopausal women, just anytime once a month. If we are talking about prostate cancer, a serum PSA level, which is prostate specific antigen. And if they are having any significant symptoms of urgent continence and frequency, urgency, okay, you can definitely go ahead and do an ultrasound and check for the post-voidal residue. That is extremely important because that's what tells you how much, if it's significant or not. If you're looking at colon cancer, post the age of 45 years, it would be a colonoscopy. If we are talking about lung cancer in a prominent smoker, a baseline CT plain can be done at the age of 45 plus years. Cervical cancer, you could get a pap smear done. Ovarian cancer, as such, there's no screening tool. But in case of any suspicion, you can do a serum CA 125 level and an ultrasound abdomen plus pelvis.
Requesting the